It's a great pleasure and an honor for me to be here, to be speaking in the Philippines, and I want to greet and honor all of those, particularly the Philippines NGO Council, and so many of my friends from the Philippines, Filipinas and Filipinos, far too numerous to name, and also my friends from the entire Asia-Pacific region and beyond. It's a great pleasure to be back here in the Philippines. And for those of you who I'm seeing and who we're meeting after our victory in the Asia-Pacific Population Conference in Bangkok, here we are again. The last time I was here was before the RH bill had been passed. And while we are extremely hopeful, as others have said, that the Supreme Court of the Philippines will do the right thing, no matter what happens, we honor the courage and the commitment of the Philippines representatives in Congress, of the many organizations who are working to bring the most basic of reproductive health to all people in this country, and to the many thousands and thousands of ordinary Filipinas and Filipinos who have taken to the streets and who have worked so hard to make change happen. I am really proud to be here with you. This session is on advances and challenges, and I'm therefore not going to repeat those broader issues that Nafis, Kate, Enrique and others have spoken so eloquently about. I'm really going to address more specifically what advances have we made in the region and where do we go from here. And I'm going to be somewhat specific and give some examples, and at the end come back to some of the broader questions that face us in terms of where we go from here with the ICPD review, with the upcoming CPD in April, and so on. In speaking about these advances and challenges, I want particularly to acknowledge a group of people with whom I've been working for the last few months to address exactly that question. What advances have we made? And where are the challenges that we must now address? One of the problems we have in this field, as we know, is because we have this noisy opposition. They keep trying to drive us back to basic principles over and over again, making it difficult for us to assess our own forward movement and where we need to be going. And I think that we mustn't lose sight of the fact that we need to really look at that and look at where we need to go very carefully, even as we deal with the noise of that opposition. So what advances have we made in the region? We all know and we say that the ICPD was a paradigm change. And paradigmatic changes really take time to come to full fruition. So when we look at ICPD progress, we must recognize the extent to which that vision has infused and entered into parallel and intersecting efforts such as the MDGs. One example I would give is, for instance, from India, which is not a country that claims that the MDGs have much to do with policy anyway, because we consider ourselves too big to be pushed by global agreements. And yet, attention to maternal mortality in the last few years in India has been much more serious and greater. And I would say that that is because of the MDG effort. But I would also say that the MDG focus really came from the ICPD. Not everything is done right, and as we know, policy change is often a messy and complex process. But we do see greater recognition in India of the links between women's health and the health, for instance, of newborns than there has been before. So what advances? First, important progress has been made towards achieving sexual and reproductive health outcomes and towards policies for SRH service provision, although much remains to be done. And we certainly await the results of the UNFPA's report that Kate Gilmore spoke about earlier. But let me give you two examples from South Asia, the sub-region in this region that is recognized as being one of the more backward ones when it comes to sexual and reproductive health and rights. Let's take Bangladesh, for example. Before the ICPD itself, there was a focus after Bangladesh attained independence on vertical family planning, on child survival, and of course on menstrual regulation. But post-ICPD, with significant inputs from women activists, we saw much greater attention to contraception and menstrual regulation, and also to emergency obstetric care. Private sector facilities began to offer obstetric care in addition to the public ones. The two 5-year national programs added nutrition and HIV/AIDS. The government partnered with NGOs to deliver services to the urban poor. Moreover, increased attention was given to violence against women, including the establishment of one-stop crisis centers in public hospitals for women survivors of violence that was recently announced. Bangladesh is widely acknowledged for its recognition of the unmet need for contraception, which is now only 11%, and a TFR, total fertility rate, that is now 2.3. Maternal mortality has declined to 194 with increasing use of antenatal care and a met need for emergency obstetric care of 56% by 2010 and 11. Abortion-related deaths are only 1% of maternal deaths compared to 1/3 in the late 1970s. And this is progress that Bangladesh can justly be aware and proud of, despite the many issues and concerns that remain. A second example that I want to give is also from South Asia, from the state of Tamil Nadu in India. The introduction of the National Reproductive and Child Health Program in the years following the ICPD increased funding and training of personnel for providing these services. And the state also responded in innovative ways to the challenges of HIV/AIDS in the 1990s, partnering with NGOs to increase awareness and provide specific interventions for populations that are at risk, treatment of sexually transmitted infections and RTIs, as well as school-based adolescent health education were also included and continue to be a central part of the strategy for HIV prevention. Major health indicators suggest the effects of these interventions. TFR in Tamil Nadu fell dramatically from 3.8 in 1981 to 2.2 already by 1991, but reaching 1.7 by 2005. A strong public health infrastructure coupled with demand-side financing through a maternity benefit scheme helped to increase the institutional delivery rate to 90.4% for the period between 2004 and 2006. Maternal mortality ratio has declined at a much faster rate than the rest of the country. Antenatal prevalence of HIV/AIDS declined to just 0.25% by 2007. And the state's policy against user fees also probably contributed to the rise in the proportion of public maternity services used by the poorest quintile of the population. And the state, particularly in strengthening health services and increasing access to emergency obstetric care, MMR in Tamil Nadu has declined now to 97, making it one of the very few Indian states that actually has met this MDG target. Deliveries in the public sector have gone up, and the state has also proved that a target-free family planning approach does not inhibit fertility reduction. The role of well-trained women field workers in delivering antenatal care, as well as other SRH services, has also played a very important role. Second, after advances in services, while countries and regions have witnessed forward movement and continuing challenges in advancing sexual and reproductive rights, the overall direction is significantly positive. This progress has been fueled, as we know and certainly know in the Philippines, by the actions and commitment of a variety of social movements, including, among others, the women's health and rights movement, youth mobilizing, and HIV and AIDS activism. And examples of advances on rights include the decriminalization of abortion in Nepal, the passing of the RH bill in the Philippines, the fact of how much support there was for sexual and reproductive rights at the 6th Asia-Pacific Population Conference that was strongly supported by the Pacific countries, whose parliamentarians had approved the path-breaking Moana Declaration. And in India, recent legislation on sexual violence, while not perfect and while coming under tragic circumstances, is a very important recognition of a major pandemic. The increasing courage of girls and women in my own country in bringing violators to book is evidenced by the recent cases of 2 interns who were interns to judges of the Supreme Court of the country, who had the courage to accuse those same gentlemen of sexual harassment. And those accusations are now under investigation and review. Imagine that. We could never have imagined it in India even 2 years ago. And in India, even the recent backward Supreme Court ruling on the infamous Article 377 is under review. And we are hopeful that because the judges who passed that retrogressive ruling made so many retrograde comments, for instance, saying that the LGBT population is a minority, a small minority. For a judge of the Supreme Court who is sworn to uphold the Constitution of India for every single citizen, the size of a minority makes no difference. And if that size has entered into his judgment, then in fact it's a judgment that is seriously open to question. So we are hopeful that this judgment will in fact be reversed. Those who argue on the basis of traditional culture, whether in Africa or in Asia, as Nafis has said, should know their own history better. The imperialist assault that the right wing keeps referring to has occurred at 2 times in our history. Once during the colonial period, on the much more open sexuality traditions in our regions, and currently through the huge inflow of right-wing funding for evangelical shock troops. There's no other imperial attack on traditional culture in our regions. We will prevail. Our people are sensible. Our courts are aware, even when they are under pressure. And time and history are on our side and on the side of human rights. The third major advance that we have made is, in fact, in the rising of young people. Large cohorts of adolescents aged 10 to 19 are demanding sexual and reproductive health and rights, education, comprehensive sexuality education, and services that are appropriate to their needs. The lives and environments of young people have changed dramatically since the 1994 conference in Cairo. But while early and forced marriage persists at unacceptable rates, as Nafis mentioned, girls in fact generally are marrying later, attending school longer, and have greater access to information and technology in a globalizing world. Nonetheless, high rates of unemployment persist, inequality and poor sexual and reproductive health outcomes overwhelm far too many young women and young men. And I'm not going to speak in detail to the demands of young people because they've spoken yesterday clearly and eloquently in their own words, as they did as well in Bali, during the CPD, but much bigger. Thailand offers an important example for us of how a move towards health sector reform and universal health coverage and sexual and reproductive health and rights can be meshed and brought together. These experiences are ones that we have to learn from, and they provide valuable lessons for approaches to universal health care that can also advance sexual and reproductive health and rights. So these are our advances. Advances in services, advances in rights, advances in the voice and agency of young people, and advances in the move towards health sector reforms, leaving behind some of the worst of the structural adjustment programs of the 1980s and the 1990s. But many challenges face us as well. And I would argue that there are 3 major gaps that particularly require our priority attention. The first is inequalities in access to SRH services and information that have left women and adolescents in the bottom 2 quintiles of the population, the wealth income quintiles of the population, who live in rural areas and other hard-to-reach areas, very far behind. If you have income, you have services. And if you don't, if you belong to the bottom 40%, you may not. And in a region that considers itself to be the growth engine of this century for the globe, this is unconscionable. These inequalities, along with and intersecting the ongoing inequalities of gender, of course, but of caste, of indigenous people, of other communities, must be addressed and must be changed. The second major gap and challenge is that As yet, the quality of SRH services falls far short of human rights and public health standards, and often even of medical ethics standards. And we must focus on improving quality. And I'm meant to say in a few minutes what I mean by this. And the third major gap is that we still, 20 years after ICPD, don't have enough by way of accountability mechanisms that can track progress, that can also track how we are meeting these challenges, how we are preventing and redressing inequalities, and how we are addressing the quality of services. We need to do much better in filling these three gaps, which reflect fundamental failures by governments and their development partners and funders to understand sometimes, and certainly to act sufficiently in accordance with the human rights foundations of the ICPD Program of Action. Improved laws and policies, as well as strengthened design, implementation, and monitoring of programs and services are required. Ensuring quality and comprehensive SRH services to all, emphasize all, especially all women and adolescents, including young adolescents, those aged 10 to 14 who are often left out, and with particular attention to the bottom 2 quintiles in both urban and rural areas, requires us to focus specifically on a number of issues, of which I will mention only 3. The first is the provision of integrated services. And we've been talking about integrated SRH services for a long time now. What do we need to do? We need to train and support healthcare providers for an increasing range of quality services, and to effectively refer clients for services they cannot yet provide. We need to assess and eliminate legal, administrative, policy, and other barriers to integration of services, in fact to all services, but also specifically to integration of services, with the priority to the removal of barriers that the most vulnerable and disadvantaged groups face. Third, we need to develop and use specific indicators to assess services integration as an important element of monitoring and accountability. And we need to experiment with the provision of multiple services in selected sites in order to learn how best to proceed with integration and how to go beyond what Nafis spoke about as the siloed provision of 1 or 2 services to the exclusion of a whole range of others. The second very important one that I speak about is in fact that question of quality. And here I'm going to focus on family planning services, just in order to be specific. But the issue of quality is not an issue only for contraception and family planning. But it's worth focusing on family planning because there is now so much more attention to family planning once again. First, the increasingly diverse clientele of family planning services require a wider range of contraceptive methods than the current minimum of 1, 2, or 3. We need services and methods that are going to be available that will work in different ways and are differently suited to diverse life circumstances of adolescents, of unmarried people. We need to be sure, therefore, that we are not just providing the one sterilization or the one IUD or the one pill. We need to broaden the range of services that are available because the diversity of needs is in fact what we need to meet. Secondly, very importantly, and this is something we've been saying for a long time, Service providers must not be incentivized to motivate, quote unquote, or persuade, quote unquote, clients to use a particular method, but must be held accountable for enabling clients to make informed and free choices based on provision of full and accurate information about side effects and the risks and benefits for that person of each method. We've been saying this from before ICPD. I think it's time that we really put this into practice, including with Family Planning 2020, which is now at the vanguard of this movement. Thirdly, procurement of contraceptive methods, of commodities, and health worker training must support women who want to switch methods. 20 years ago and today, as many as 35 to 40% of contraceptive users discontinue use within 6 to 12 months for reasons related to the quality of services. And they either don't know about or are not supported by service providers to choose an alternative method. Of particular importance, therefore, is ensuring that SRH service providers have both skills and instructions to give higher priority to condoms in the era of HIV and STIs, and to remove contraceptive implants and IUDs on request. Healthcare providers must be trained and supported not only to meet medical standards, but with much greater emphasis to respect the human rights of the persons they serve, particularly non-discrimination, especially for young people and unmarried people, ensuring privacy, confidentiality, and choice, with special support to those who may not be experienced decision makers, such as young married women and adolescent girls, to provide full information on the possible importance and impact of contraceptive side effects for each individual, and to assist girls and women to weigh their risk of STIs and HIV when deciding what contraceptives to use. Finally and thirdly, planning for and monitoring progress in meeting the challenges. What we don't monitor, what we don't count, doesn't get any attention. So there's an urgent need for a fresh look at the entire range of SRH measures to assess how well policies, programs, and services are progressing towards equality, quality, and accountability, while addressing the principal gaps and bottlenecks in continuing ICPD implementation. And few of the indicators currently used to track SRH services effectively address equality or quality or accountability. For example, measures such as couple years of protection and current strategies to reduce unmet need tend to favor long-acting contraceptives and sterilization, which have high intrinsic couple years of protection attached to them, are not subject to user failure, and require less resupply, especially for women in rural and other hard-to-reach places. Such measures can subvert human rights standards, which require that clients have an unbiased choice among a wide range of contraceptives appropriate to their specific needs. And it's time that we bite this bullet. We need new indicators that will in fact appropriately meet these. And I don't have time to get into that here, but I hope that in our discussions we can do that. Similarly, tracking comprehensive sexuality education has so far emphasized evaluations of impact, which is technically challenging and costly. But it would be far more useful, for example, to track instead the proportions of adolescents aged 10 to 14, 15 to 19, who have access to monitor the quality of content and the delivery once national standards are set, and to assess the extent to which curricula and teaching use the UNESCO guidance that already exists. More generally, greater emphasis needs to be on equity and quality as critical components of progress. Ladies and gentlemen, I've tried to be in this talk a little bit specific so that we go from brave words to looking at what are the very specific things that both from the civil society side and from the government and agency side we need to pay attention to. But let me say a few words in conclusion about what faces us in the broader landscape. We all know that we have now entered 2014, and we've been looking at 2014, upcoming 2014, for a number of years now. We've been preparing for it, we've been advocating for it, we've been fighting for it, we've been arguing over it, and hopefully we will be successful by the time we get to September. But ahead of us we have the Commission on Population and Development, which hasn't yet determined what kind of outcome document or what kind of negotiation will in fact happen. The Asia-Pacific region has in fact supported its bureau member to be in favor of the normal, regular CPD negotiation. If we back off at this point from such a negotiation, we will in fact have much less with which to go forward towards the post-2015 agenda or even the post-ICPD 2014 agenda. So we will in fact need to negotiate, and this region, and I would argue very strongly that we need to continue to advocate very strongly that we must have a full, regular, normal outcome statement coming out of the CPD, which we will of course have to fight over it. So what's new about that? We always fight over it. But we need to know from our victories. Who knew, for instance, in Bangkok in September, that the Pacific would rise to the occasion in the way that we did? Certainly I didn't. And it was an enormous pleasure and surprise to see that. But it also means that change is not just in the air, it's everywhere. And I think that we need to take courage from that and be willing to push our governments and be there ourselves to move this forward. So thank you very much, and I hope to be with you in the upcoming battles and the upcoming victories that we will gain in 2014. Thank you.